Good afternoon, everyone. I'm Don Wiley, President and CEO here at St. Joseph's Medical Center. And this is, I think, our third or fourth community update during the COVID-19 pandemic. I'm very grateful for both Dr. Scott Neeley and for Dr. Maggie Parks joining us today, as they're going to be doing most of the presentation, but I'll start off, and let's just advance the slides and do a welcome, reflection, and overview. This is what we're going to cover: a quick update on the hospital, mostly as it relates to COVID, and then we'll turn it over to Dr. Maggie Parks to talk about the county and the numbers and what she sees in terms of the future. And then Dr. Neeley will talk about some of the clinical work that we're doing and what's working and what's not working. And an update on the vaccine, which I think everyone will find very interesting. So let's get started. So these are a couple of reflections. We like to start our meetings with a reflection, and if you just take a moment and take a deep breath. And the first one is from Nelson Mandela. It always seems impossible until it's done. And the second one from Samuel Jackson: great works are performed not by strength, but by perseverance. Let's talk a little bit about the numbers at the hospital. This is our dashboard. It's actually 2 days old. We just got our new dashboard this morning, but it's very similar. As of Wednesday of this week, we had 1,312 unique COVID positive inpatients at the hospital, and a vast majority of those patients have been discharged alive or are still in the hospital. But we have had 256 deaths just at St. Joseph's. And so that gives you an idea that the mortality rate is around 21% for the patients we've taken care of. That's very similar to the rest of the country. And we are seeing better performance now. When you see Dr. Neeley's slide, particularly as it relates to steroid use in our sickest patients, you'll see why. About 26% of our patients, looking at the middle of the graphic here, have been in the ICU. And if you look to the left of that little gray part of that circle, 16% of patients have ended up on mechanical ventilation in addition to being in the ICU. Gender, 50-50. Race and ethnicity, 40% Hispanic. I think that's representative of our community. And if you look at the lower left-hand bottom, you'll see that 55% of our patients are 61 years or older, but we have had almost half of our patients have been younger. And when Dr. Neeley talks about mortality, I think he'll mention a little bit about some of the younger patients he sees as a palliative care doctor. And the last little quarter on the right-hand side on the bottom, you can see that in July, we had a real kind of a aggressive ramping up and then a peak the next to the last week of July. And on July 27th, we had the most COVID positive patients in any hospital in Northern California, 115, with 96 of those patients being admitted just days before that. And you can see in the last 2 weeks, and I think what we will see on Saturday when we publish these numbers again on the 19th, that we have had 3 record weeks in a row in terms of volume. Next slide. This is a slide that shows the numbers for San Joaquin County. We hear a lot about ICU capacity and what that means for closures and shutdowns. And you can see here on the 4th line, the ICU capacity for our county, we are at 125%. There's no hospital less than 100% of their ICU capacity, meaning every single one of their licensed ICU beds has a patient in it. And in our case, at St. Joseph's Medical Center, we actually have 52 ICU patients 2 days ago with 39 licensed beds. We are able to operate more than our 39 licenses, but we clearly are 133% of our ICU capacity. Next slide. This slide shows at the top line the number of COVID positive patients in each of the hospitals and the total. So 329 total ICU patients, COVID positive inpatients in San Joaquin County hospitals. And you can see how that breaks down. I also would point out that, again, 74 ICU patients. That's just the COVID patients in the ICUs of those hospitals. And then below that, 59 of 74 COVID positive patients are on ventilators in those ICUs as of 2 days ago. You can see we had 52 admissions that day and 42 discharges, but we also had 12 deaths, which I think is a record number for San Joaquin County. Next slide. At St. Joseph's, we've cared for about 40% of the COVID positive patients in San Joaquin County, the inpatients. And that's been pretty consistent throughout the pandemic, and maybe a little less as of today. But we have the most experience of anyone. We have had some of the highest numbers. And on that July 27th date I mentioned to you, with 115 COVID positive patients, we had the most COVID positive patients in any Common Spirit Health hospital that day. That's 140 hospitals in 22 states. And we had the most patients of any hospital in Northern California on that day. Last week or earlier this week, we had as many as 134 patients. Today, we're at 128. Rapid implementation of state-of-the-art care here, both in the ICUs and on the med-surg floors, both investigational treatments and then rapid education of our physicians and our nursing staff. Dr. Neeley will talk about some of the specific treatments. We expanded our ICU capacity from our current licensed capacity to 70 beds twice now, including currently, and we have had enough staffing to do that. We do have a staffing waiver approved by the state of California CDPH that allows us to change our ratios in not only the ICU, but in other departments. And we have tried to use that sparingly, but we have had to use it, both because of not being able to provide break and lunch relief, even if we are meeting ratios, or because we haven't had enough qualified ICU nurses. We've teamed them up with other professional nursing staff, RNs from telemetry units, to extend the expertise of the ICU nurse. We have sufficient PPE and equipment, and we have actually brought in about 100 traveling staff during the last few months, many of whom are rotating out in December and January. And as they do that, we will have more challenges. And our investment just in that staff is close to $2 million a month, about $1.7 million a month in that extra staffing in order to try to make sure that our staff have the team they need to take care of patients. We began vaccinating with the Pfizer vaccine. We have a super cool freezer, which allows us to store that vaccine. And so we got a very nice allocation from the state through the county. And I would just say we've had exceptional leadership from our management team, physicians and nursing staff, and other frontline workers here. And finally, just looking quickly at this, this is just testing. So it's both, the blue is the number of tests done in a day on the left-hand axis, and on the right-hand axis, the percentage in orange of those tests being positive. You can see the June and July surge, and now you can see the November and December surge looking very similar. We don't know what's going to happen next. It's been a steeper line, but we are seeing kind of a plateau as of this week. Next slide. So it's my pleasure to introduce Dr. Parks, who's a public health officer here in San Joaquin County. Perhaps the most difficult job in our county right now. And she has just done such a terrific job providing leadership to the public health for our community. And it's certainly a no-win situation for her to make the right decision every day when she comes to work. So let's turn it over to Dr. Parks.
Thank you, Chief Wiley. So I'll just give a brief update about COVID and the numbers as they are today in San Joaquin County. This is our epi curve, as we call it, which tells you bar by bar how many confirmed positive cases of COVID there have been since the beginning of the pandemic. And you will see that here in the summertime, we got up to some very high numbers, approaching almost 500 confirmed cases on any given day when we surged back in July and August. We were approaching that number several weeks ago and hoping not to surpass it, but as you can see, we have clearly surpassed that number with some days as many as 700 and 800 confirmed positive cases on a single given day. The more recent bars, as you'll see as we go into the more recent dates, those are still low-looking bars, but they're likely to be updated, and these bars will get higher as we backfill information and get more confirmed cases in our data system. Next slide. So just want to bring this to your attention. I've been saying this for some time now, but if you look at the data, you'll see that if we look by age group, that this gray line, which represents our younger adults, and some of these other lines as well, represent some of the younger adults who are really having more confirmed cases per their rate of population in our county. So that right now, this age group of 25 to 34 has the highest rate of COVID. We believe that some of these younger adults tend to be mildly symptomatic or maybe even asymptomatic and don't realize they have COVID and are still showing up to work and going to other functions such as gatherings and perhaps being somewhat of silent spreaders, which is why we do encourage everyone to get tested and to follow the rules of washing your hands, masking, and keeping your distance, because you just don't know if you might be one of these folks. Next slide. Looking at some of the data, and I know that Mr. Wiley already presented to you the numbers by table form, but you can see here graphically how the summer surge ended up having a peak of 262 people in the hospital on the highest day. And as he showed you before, we do have a lot of people in our hospitals and our ICUs to the point where now above what our summer surge was. We have more people in the hospital at 329 as of yesterday in the hospital. And the red line tells you how many people out of those 329 admitted in our hospitals are in our ICUs, and that stood at 74 yesterday. Next slide. So as you all know, we're in a regional stay-home order, and 4 of the 5 regions in the state of California are under this stay-home order, which basically prohibits gatherings of any size and closes some operations that had previously been open and requires everyone to do 100% masking and physical distancing. This stay-at-home order was something that was mandated on December 3rd to occur in any region that had less than 15% ICU bed capacity. And as you'll see on any day since that order came out on December 3rd, other than that very first day that when the order came out, we have been below that 15%. And in the most recent weeks, we've been as low as 0% as a region for ICU capacity based on the way the state calculates the regional availability of beds. This number is posting today as again being at 0.0 for December 18th, unfortunately. And next slide. So what does the regional stay-home order do? And I won't read this, word for word, because this is something that you could obviously look up, but it basically kept some things like critical infrastructure, schools, medical, dental care, and child care open. And what it did say was that some of these other things had to be modified. For example, grocery stores could be open at a 35% capacity, retail could be open at 20% capacity, restaurants had to only be open for takeout and delivery, so on and so forth. And next slide. And as you probably all know, these are some of the things that had to close. Unfortunately, our hair salons and barbershops, personal care services, other entertainment types of things have had to close. And these sometimes, it's difficult to know what's open and what's closed, but if you go to the covid19.ca.gov website, you could plug in our county and actually look up our laundromats open, our car wash is open, is pet grooming allowed, and you could look those things up and you will see by our county what is and is not allowed. And next slide. So this was just a very short presentation, but I want to end. I know that Dr. Neeley is going to be talking about vaccines, so I won't go on about it for too long, but just to let you know that the state's campaign is called Vaccinate All 58. And in our county, we're going to be calling it Vaccinate San Joaquin. As you know, we've rolled out vaccines. As of Tuesday morning, we received some Pfizer vaccines. They went out to all 7 area hospitals in the county so that they could start in on this healthcare worker group, which is in that very first tier of recipients. So I'm very pleased and excited that this process has begun, and we will continue to phase in more vaccines, distribute them out to our hospitals and our healthcare partners as we move along this process. So thank you very much.
Thank you very much, Maggie. How's my sound?
Sounds good, Scott.
All right, great. Thank you very much. Good afternoon. I'm Scott Neeley, and I am the Chief Medical Officer at St. Joseph's Medical Center. I'm going to talk a little bit about COVID-19 treatments, as well as COVID-19 disease prevention, and a little bit about staying safe. Can I have the next slide, please? As we have gone through this pandemic, and as Mr. Wiley mentioned, we've cared for over 1,300 acutely ill patients with COVID-19 disease at St. Joseph's Medical Center. And we have worked very hard to both stay up on the evidence in terms of what works and what doesn't work, and to quickly innovate and adapt to effectively treat our patients. What we have learned, and what many others have also learned, is that probably the most important new treatment thus far for treatment of COVID-19 disease is actually an old drug. It's called dexamethasone. It is a steroid drug that has previously been used to treat a variety of inflammatory conditions, conditions where the body's inflammatory system or defense system actually is causing problems. It was determined in a very large trial that dexamethasone actually improved mortality in patients with COVID-19 disease. And what this data shows, if I can call your attention to the right upper corner, is that dexamethasone improves mortality most markedly in the sickest patients. It actually improves outcomes in all patients who were studied in this large controlled trial, but it has the biggest impact in the sickest patients. And as Mr. Wiley mentioned, we have seen some decline in mortality rates due to COVID-19 over the last 9 months, and probably the treatment that has made the biggest difference in terms of improving mortality rates is dexamethasone. Interestingly, there are no true antiviral treatments that have yet shown an impact on mortality. This being really the sole and most important treatment in terms of actually improving a patient's chance of surviving once they develop severe disease. Can I have the next slide, please? A few other treatments that you have heard about, and I'm going to sort of quickly review. The first is remdesivir. Remdesivir is an antiviral drug originally developed with the hope that it would be effective against Ebola. It wasn't, but in some studies that have been performed both here and internationally, there seems to be mild antiviral activity for remdesivir against COVID-19. What's been demonstrated is that remdesivir seems to shorten the duration of illness in people who are mildly ill. In other words, a patient may be able to be discharged from the hospital a day or two earlier if they receive remdesivir. However, there have been no studies that have shown that remdesivir improves survival, and remdesivir does not appear to have any impact in people who develop very severe disease. And that's been documented in fairly large randomized studies where patients receive either remdesivir or a placebo drug. Convalescent plasma is another treatment that's gotten quite a bit of press. Here we're talking essentially about antibody therapy, and we're going to talk a little bit more about antibody therapy. But in patients who have survived COVID-19 disease, there is a production of antibodies against the virus. Antibodies are proteins that our body's immune system produces, which bind tightly to proteins on the outside of the virus, almost like a lock and key mechanism. And once they bind to the virus can then be killed by the body's other defense systems. So antibody production is very critical in our defense against the virus. Infusing blood plasma, in other words, the liquid portion of blood that's separated from whole blood and is protein rich in these antibodies, transfusing convalescent plasma from people who have survived COVID-19 into acutely ill patients may actually be beneficial. The data on that is inconclusive with regards to whether convalescent plasma improves survival, but there, I would say, is enough evidence to make us at least suspicious or hopeful that convalescent plasma improves survival, that we are continuing to give this treatment in patients with early disease. There are two other treatments listed there that are newly released. One is the Regeneron treatment, which includes two monoclonal antibodies, casirivimab and imdevimab. I think they make those words intentionally very difficult to pronounce. The combination of these two monoclonal antibodies acts by the same mechanism that we talked about with convalescent plasma. These monoclonal antibodies bind to proteins on the outside of the virus and then allow the body's immune system to more effectively clear the virus. Bamlanivimab acts in exactly the same way. So these treatments are equivalent, and the beneficial effects of these treatments seems to be relatively equivalent as well. These are still considered experimental treatments. They have not received FDA approval. They are available on what's called an emergency use authorization. They have received some publicity because the Regeneron treatment is the treatment that President Trump received when he developed COVID-19 disease. The effect of these treatments is seen basically in people who have fairly mild illness. And what we believe is that people who have mild illness, but who have a significant risk of developing more severe illness, may benefit from these treatments. What's been shown is that this population of patients, if they receive the monoclonal antibody treatment early, seems to have a lower risk of developing severe disease and needing hospitalization. Perhaps as much as an 80% reduction in the risk of developing severe disease in those patients. So who should receive this drug? People who are symptomatic, so who are short of breath, but have not yet progressed to severe disease. And severe disease is usually defined by somebody who requires oxygen therapy. We believe that it's potentially the case that giving these treatments to people with severe disease may actually make the disease worse due to making the body's inflammatory response more pronounced. And so they're only approved to give to people who are symptomatic with mild disease who have risk factors. Those risk factors would be age, over 65, would be obesity, since those patients have worse outcomes, diabetes, heart disease, high blood pressure, a few other conditions as well, which may predispose to making somebody at higher risk for developing severe disease. We are giving these treatments in our emergency department to outpatients who are being discharged home. It's actually a little difficult to find that patient, that person who's kind of in the sweet spot of having relatively mild disease, but being at high risk for progression to more severe disease. But we have access to these treatments as a result of distribution by the county health department and EMS. And we have given a few patients the treatment. Can I see the next slide, please? Okay, so kind of summing up what we've learned in terms of taking care of very ill patients with COVID-19 disease, and something we really want to emphasize and have the community understand is that this is not the flu. This is a profoundly dangerous infection. It's dangerous for a number of reasons, in large part due to its rather unique characteristics. Those of us who have been practicing medicine for a while have never seen anything like this. This disease ranges everywhere from the most benign or even absent symptoms, so people with asymptomatic disease, to people who are as sick as we have ever seen, people with the most severe type of lung disease that we've ever seen, and many, many of them. It's asymptomatic in 40 to 45% of people, but in people who develop severe disease, they have a very significant risk of hospitalization. And in people who develop the most severe form of the disease, who, for example, require intubation and mechanical ventilation, mortality rates routinely exceed 50%, which is like really nothing that we have ever seen before in modern critical care medicine. Age and comorbidities are highly associated with mortality. So most of our mortalities are in people who are greater than 50 years of age. And most of our mortalities also occur in people who have high blood pressure, diabetes, obesity, cancer, chronic lung or heart disease. But I have to tell you that one of the things that's been most tragic about this disease is that it has taken so many of our neighbors in the community, many people who are really still in the prime of their lives, matriarchs and patriarchs of young families, people whose grandchildren had every right to expect 20 or 30 years with their grandparents, have been killed by this disease. And, you know, as a palliative care physician who meets with the families of our most ill patients, this has been a tragedy of just, you know, mind-bending proportions, given the number of people in our community who have lost their lives and the number of families in our community who have lost loved ones. It's been absolutely devastating for many, many families in our community and many, many families across the country and the globe. And I emphasize that because there has been communication out there in various forms suggesting that perhaps this isn't all it's cracked up to be, or that people are dying from other causes and having their deaths attributed to COVID-19. This is false information. This is a deadly and extraordinarily infectious disease, like nothing that any of us have ever seen in our lifetimes. And it is a national tragedy and a personal tragedy for literally thousands of families in our country. Next slide, please. I want to talk a little bit about vaccine now, because this is the hope for us coming out of this tragedy. Numbers are good, and an increasing number of Americans say that they will or probably will get the COVID-19 vaccine, but there are still some who are concerned about getting the vaccine and are hesitant, in most cases due to misinformation. Some of these common myths include that the vaccine was rushed, it was not tested enough, not enough is known about it, the vaccine has a lot of side effects, people are concerned that they could get COVID from the vaccine, or that the vaccine could somehow change our DNA. These are myths. This is misinformation, but let's talk a little bit more about that. Moving on. The vaccine development has been probably one of the greatest accomplishments in medicine during our lifetimes. Literally hundreds of vaccine candidates are in the preclinical stages of development, and several of these vaccines have moved on to what are called phase 1, 2, or 3 trials. The reason that this was able to be accomplished so quickly is the coincidence of amazing new techniques in molecular biology and vaccine development, with a real willingness on the part of governments to fast track the development of the vaccine. With these new techniques and essentially enormous resources, i.e. money, being thrown at vaccine development, medical scientists were able to accomplish something that has never been accomplished before, and that is the development of highly effective vaccines in less than a year. It's really a marvel, and I personally just feel so grateful that we live in a country, live in a place where science was able to be applied in such an extraordinary way as has been done in the development of these vaccines. Let's move on. So this is a little bit of a busy slide, but I do want to talk about how our most promising vaccines have been developed. And I want to call your attention to the left side of the slide where it says mRNA and a lipid shell, or RNA vaccine. Both the Pfizer and the Moderna vaccines are RNA vaccines. This is a technique that has never been used before in a human vaccine, but it is an extraordinary and appears to be a highly effective technique. Essentially, RNA, which is the code which is used to make a protein from the virus, is placed into a micro or nanolipid membrane and injected. The lipids are the same composition as cell outsides or membranes or exteriors. And the lipid can basically combine with the outside of our cells, releasing the RNA into the inside of the cells, where the cell's mechanism uses the RNA to actually make a viral protein. This is actually mimicking the virus's mechanism of action, but doing it in an extraordinarily safe way, because you're not producing a live virus. The only thing that you're producing with this technique is the viral protein. It's actually the spike protein that's on the outside of the virus, which the virus uses to bind to our cells and infect us. So once this viral spike protein is produced by our own cells, our body recognizes it as foreign and begins to produce an immune response to it. It makes antibodies which bind to that protein, and it activates what are called T cells, which function in killing viruses. And so once that immunity occurs, and it takes just a few days for that to happen, our body is basically primed, locked, and loaded to kill virus if we're exposed to an adequate quantity of virus to actually cause an infection. This is essentially the principle by which all vaccines are made, but this new mRNA technology is producing a vaccine which appears to be both highly effective as well as extremely safe. Let's move on. So we've talked a little bit about the spike protein that the messenger RNA codes for. And importantly, because of this, the vaccine cannot cause SARS-CoV-2 infection. It doesn't contain the code that's necessary to produce a live virus, only the code that's necessary to produce that spike protein that's on the outside of the virus. These vaccines have now been studied in tens of thousands of people. In the Pfizer study, over 44,000 people were enrolled in the study, and that means that 22,000 people got the vaccine and 22,000 people got a placebo. In the Pfizer study, over 38,000 participants have been followed for a median of 2 months. That's an important guidepost, that 2-month period, because significant side effects of vaccines typically occur prior to 2 months. And after 2 months of follow-up in tens of thousands of patients, it's been determined that this vaccine is extraordinarily effective. And we have seen essentially no serious adverse events related to the vaccine. There have been no deaths related to the vaccine, and there have been no serious complications related to the vaccine in the Pfizer study. Same was essentially seen for the Moderna study, but that vaccine is a little bit earlier along in development. And so we haven't had a chance to look at as much of the Moderna data yet as we have with the Pfizer vaccine. But the FDA has given the Moderna vaccine an extremely positive review, and we expect it to be receiving its final emergency use authorization today, with shipments starting to occur probably over the weekend or early next week. Let's go to the next slide. This slide actually shows the data from the Pfizer study, and it shows the incidence of infection for the two groups. The group represented by red symbols is the control group. They did not get the vaccine. And the group represented by the blue symbols represents the vaccine group. And what you can see here is that starting at day 0, that's the day that the recipients received the first of 2 doses of vaccine, the control group starts to get infected with the coronavirus. And you can just see that gradually over the course of 120 days that this data is reported, you've got a fairly large number of infections in the people who did not get the vaccine. On the other hand, starting 7 days after day 0, 7 days after the recipients got their first dose of the vaccine, the two curves diverge very markedly, and there were extremely few infections in the treatment group. Now, this treatment group received a second vaccine injection around day 21, and what you can see here is that about half of the infections that did occur in the vaccine group actually occurred before the second injection. And there were only, I believe, 9 total infections in these 22,000 recipients after the second dose. So an extraordinarily effective vaccine, really one of the most effective vaccines that have ever been produced against the virus. Next slide, please. So who's going to get the vaccine? What's the timing of this rollout? There is a certain amount of uncertainty over this, though we are following recommendations from the National Academy of Medicine and the CDC in terms of how we roll out the vaccine. Right now, we're working on phase 1, and it was recommended that high-risk health workers, essentially anybody with a patient-facing job, and first responders be in group 1A. It was also recommended that people with all ages with severe underlying conditions also be considered in group 1B, and older adults living in congregate or overcrowded settings, i.e. Nursing homes or other types of care facilities. So we are working through phase 1 right now. There will undoubtedly be some changes in this phased recommendation for how we roll it out. And there is some uncertainty as to whether we will, when we will have, number 1, enough vaccine, and number 2, the infrastructure in place to give all these vaccines. Because as Dr. Fauci has said, making a vaccine is one thing, getting it in people's arms is another thing. In order to safely and effectively do this, as well as to give the follow-up doses of the vaccine, you have to have resources in place. You have to have a structure and a process in place to make sure people are getting appropriately registered, and that we're giving people the information to follow up for their second dose, that we're giving them the information to report any side effects of the vaccine. So it really takes some doing to actually get these vaccines into the arms of 300+ million Americans. But that's what we're starting to do now. I think that there is an expectation that mass vaccination may start to occur in February or March, but there is still, unfortunately, some uncertainty about that. One thing that I do want to mention is with the Pfizer and the Moderna vaccine, if you get the Pfizer vaccine first, your second shot has to be the Pfizer vaccine. Same is true for the Moderna. There's no mix and match there. And so that adds, sort of a new level of complexity to that task. Next slide, please. So what we're saying is hope is springing up everywhere, and we can see the light at the end of the tunnel with respect to this pandemic, but we've got to stay safe together. We have to stay safe until we get that vaccine in our arms. Get a vaccine when available and educate your colleagues, your friends, your loved ones. There really is almost no contraindication to getting this vaccine, and there is every reason to expect that the benefits of vaccination far, far, far outweigh the risks. Not only that, getting a vaccination probably protects the people around you because it very likely will keep people not only from getting the disease themselves, but spreading the disease. The new Moderna data does suggest that. We've got to keep the safety practices up until the pandemic is over. That means wearing a mask, physical distancing, and hand hygiene. We have to do this because we have to continue to slow the spread of the disease in order to resume our businesses, our commerce, our education. We have to do it to protect our vulnerable communities, and we have to do it to protect the functionality of the healthcare system. As Mr. Wiley said, we're operating at an extreme in terms of our capacity right now. And in order to deliver life-saving healthcare to everyone, both people with COVID-19 as well as people with other conditions that merit medical treatment, we've got to slow the spread of the disease and keep our healthcare systems functioning. The new normal is safe medical care for everybody. And that means robust care for COVID patients, but it also means keeping people safe and keeping healthcare systems functioning so that we can take care of people with strokes and heart attacks and other emergency conditions that need to be treated. Next slide, please. At St. Joseph's Medical Center, we have been focusing with a laser beam-like approach on safety. And this is data showing safety events at our hospital and the incredible success that we've had in decreasing safety events. And what I mean by safety events is harm to patients due to error. You've heard about this in the press, in the medical literature. People are rightly concerned that they're going to have a complication when they go to the hospital. We're committed to everybody being safe, to completely avoiding medical complications that can be avoided. And we've had tremendous success, even during the time that we've been dealing with this pandemic, in lowering the rate of complications, lowering the rate of safety events, lowering harm to patients as a result of inadvertent error in this extraordinarily complex medical system that we work in. Next slide, please. We talk a lot at St. Joe's about our purpose because our organization is deeply committed to serving our community and to serving every single person who comes to us in need. And our purpose is exceptional care for everyone with dignity and human kindness. We look forward to continuing to partner with our community and accomplishing that goal. And I think that we have some time now for questions.
Thank you very much, Dr. Neeley. That was terrific. And thank you, Dr. Park. Dr. Park, one of the questions I get all the time from our community is, how do we know these patients don't just have the flu when we test them for COVID?
Well, sometimes the symptoms do seem to mirror each other, and there is some overlap. And so you don't know exactly if someone presents with symptoms that could be either until you do the testing. There are tests that are available now that could test for both, and there are certainly ways that you could do separate testing for both. But either way, whether you do tests that cover both flu and COVID or you just do them separately, really, once you do the testing, that's how you know. So people who come in with symptoms that could be either should really be tested for both.
And I know here we're doing that. Anybody we're testing for COVID is getting influenza A and B, and I think RSV, so that we know. And to my knowledge, we're reporting to the county all the positive flu tests. We haven't had any. So part of Dr. Neely's message about masking, even if you get a vaccination for COVID, can do a lot of good for our community in terms of resource consumption in the healthcare sector. So I was kind of using you a little bit, but I appreciate your answer on the testing, because that's very important for people to know. We test everybody for influenza A and B when we're testing for COVID during the winter.
Thank you. And just briefly, I'll say that by this time last year, we had 3 flu-related deaths, and we've had none so far. So I believe that the masking and the distancing is effective for flu as well as COVID.
Very good. Natalie, what other questions do we have?
I do have questions. There's a couple in the chat I'll ask first. One of them is they heard a rumor that the vaccine, some people are getting Bell's palsy. Is this true or a rumor?
I can address that. It's interesting that that one has gotten out there so quickly. In both of the large trials, in the Pfizer trial with 44,000 patients, and in the Moderna trial with 25,000 patients, each population developed 4 cases of Bell's palsy. And there was a predominance of Bell's palsy in the vaccine group. That was not a statistically significant result. And so it's not being reported as a complication related to the vaccine. The other thing that's important about that result is that the incidence of Bell's palsy in these populations was lower than the general population incidence of Bell's palsy. Bell's palsy is actually a fairly common problem due to inflammation affecting a nerve in the face. And it can occur after any infection. And so essentially, while there were cases of Bell's palsy seen in these study populations, the FDA is following that. We can still say with a great deal of confidence that the risk of complication due to the vaccine is far, far less than the risk of actually getting the infection, where the mortality rate is probably about 1%.
And just to say a little shorter, if you weren't in the study, you were just as likely to get Bell's palsy as if you were.
Another good way of saying it. Thank you.
Another question is it safe for pregnant women and lactating women? And were there any pregnant women as part of the trial?
Pregnant women were not studied as part of the trial. And the recommendation is that pregnant women consult with their physicians and individually consider the risks and benefits of vaccination. There isn't really a mechanism by which the vaccine would be logically known to harm a fetus or a pregnant woman. It does induce an immune response, and there can be unknowns associated with that, but it does not cause an infection. Like, some vaccines actually induce an infection, but this one does not. And so logically, we wouldn't have a really high suspicion that it would harm mother or baby, but that is something that is really being left up to the individual obstetrician and mom in terms of the risks versus the benefits. And it's not something that's been studied yet.
Thank you.
And I agree with Dr. Neeley on that one, and just quickly want to add that although pregnant women weren't entered in the study, some women became pregnant during the study, and they didn't have any bad outcomes.
Thank you. This says, how can we be assured that the vaccines are being kept at the proper conditions during transport to maintain their efficacy, and have the receiving facilities receive training on how to handle them upon arrival?
That's a great question. The first answer to that is that Moderna and Pfizer have designed a very sophisticated transport crates for the vaccines. The transport crate, the vaccine for Pfizer, which has to be kept at the colder temperature, is shipped in dry ice. There is a a thermometer monitoring the internal temperature of the crate during the entire shipment process. And the monitor is actually transmitting data on the internal shipment of that crate to Pfizer using a radio transmitter and then, internet technology. And so they are able to document the so-called cold chain, the temperature of the vaccine for the entire storage and shipment process. Only organizations that have been certified to handle the vaccine are receiving the vaccine. So as Mr. Wiley mentioned, we have a -90 freezer. The county has a -90 freezer, but only organizations who have the capability of safely storing the vaccine are receiving it. It is possible to actually safely store the vaccine in the shipment container and basically redose the container with not liquid nitrogen, but dry ice. But a great deal of planning has gone into safe handling of the Pfizer vaccine. The Moderna vaccine only needs -20, so it's not as demanding to safely handle the Moderna vaccine. I would also add that, if you get steaks from Snake River Farms or Omaha Meats, the Pfizer vaccine shipment technology is exactly how you have your steak shipped in dry ice. So it's not something that people have not accomplished before.
And then once the vaccine is put into our super cold refrigerator or freezer, then we're able to monitor the temperature there, and an alarm goes off if it reaches a certain temperature that would be higher than would be keeping the vaccine safe.
This question is, if somebody, how will someone know when they need to get their second dose, and what happens if they don't take it in the time frame? Do they have to start back at step 1?
The answer to that is, and Maggie, jump in if you have something different, but you can, for the Pfizer vaccine, you can receive your second dose starting on day 17. If you miss day 21, it is still advised that you get the second dose and you do not have to start over. The guidance is certainly that you get your second dose right around that 21-day mark. But the guidance is also that if you overshoot the 21-day mark, you still get the second dose and you do not have to start the series over. For Moderna, the distance between the doses is 28 days, and I haven't seen the precise guidance on that. Maggie, anything else?
No, that's exactly correct. The guidance is that if you're late on getting your second dose, you still get it and you don't restart the series. And everyone who gets that first dose will receive a card that says you were vaccinated and remind you of the date that you have to return. So there is a reminder process in there built in.
This would be for Dr. Park, and it says, regarding the regional boundaries and the stay-at-home order, once ICU bed capacity below 15%, do smaller communities within that larger region have the opportunity to open, or do they have to stay closed because the whole region as a whole?
No, you have to stay closed. Unfortunately, the state is not going to be looking at different communities within the San Joaquin Valley region. So the entire region entered the stay-at-home order together, and we must exit it together once the region has met that 15% ICU capacity. And the projection is made that in 4 weeks' time that we could hold that capacity. So there's no possibility to do that in certain areas of the region.
Are
Maggie,
recipients notified? I'm sorry.
Sorry. Maggie, is there any early indication or leading indicator of a change in the direction of the infection rate?
Right now, we're surging and we continue to surge. So unfortunately, not only regionally is there 0% ICU capacity, but locally, even if we were to look at our local communities, as you had said earlier, our ICUs are full in our county. So there wouldn't be any part of our county that would really have met that 15% or less, even if you went hospital by hospital. So the case rates back when we were in the red tier were at 7 per 100,000 population, and now we're at 68.4. So it's gone up every week since we entered this order.
So nearly a 10-fold increase in infection per 100,000.
That's correct.
These two questions have to do with ICU capacity. One is, what happens when our ICUs are at 0%? How do hospitals adjust? Are patients being sent to other hospitals? And the other is, with the capacity, are goals of care conversations being held sooner than normal, and how are families receiving those communications or those
Can I take that one,
conversations?
Don?
Yeah.
Okay. First off, sounds like the question came from a fairly sophisticated member of our crowd here. We have expanded our ICU capacity from 39 to 70 beds at St. Joe's. We're running in the 60s right now, but we have expanded our ICU capacity, and we actually have further ability to do that. We have challenges in terms of space and equipment, but we have more challenges in terms of staffing. Currently, we have enough space for our patients, and we are running tight in terms of staffing. But thus far, we've been able to mount a pretty robust surge plan, and we are continuing to keep our patients safe. In terms of the goals of care conversations, we have worked to have those conversations sooner, and we have worked to identify people who have a very poor prognosis and to have conversations with them and their families as soon as possible. These conversations are the most difficult ones that we have. And, I emphasize this to some extent in my earlier talk with you, but I cannot possibly overstate the personal impact that this has had on people in our community, both because they can't be with their loved ones in the hospital while they're sick, and because so many families have actually lost loved ones as a result of this disease. But yes, we are working very hard to make people aware when there is a poor prognosis and to allow them to have a dignified natural death if that's really what the patient wants or what the patient values and what the family understands to be that patient's wishes.
Several questions are about vaccinations and when. One is, what's the plan for children under the age of 16? One question is, as an older person with health conditions, how would you know when it's your turn to get the vaccination? And the other is people who work in other essential roles, how will they know when it's their turn to get the vaccination?
Yeah, thank you for that question. And we learn more from the state as we go. And Dr. Neeley did show that slide with the phase 1, 2, 3, and 4 that came out from the CDC and the National Academies of Science. And even that graph is constantly being looked at again and revised. So that's been moved around. For example, residents of skilled nursing facilities are no longer in 1B, they're now in 1A. And as the CDC makes decisions like that, the state of California looks at it and decides whether to adopt that change or not. You will see that children were put in stage 3 or phase 3, and studies are ongoing about the vaccine used in children under 16. For other people who might be in critical infrastructure, they would be in that phase 2 on that graph. However, exactly which industries are considered more critical than others and more exposed and more at risk are still being parsed out. So time will tell. All of the planning is going on. There's constant meetings with the state and the counties, and we find out more as each day goes by.
Thank you.
Would both of you be willing to have another community call in maybe a month if we learn more?
Sure.
I think we're going to need it.
I
Great.
have additional questions. Are we okay to stay on for a few more minutes?
Let's go for 5 minutes and then let people go. We're losing a little bit of our audience, but we still have 185 people on.
Yes. One person says, are people that receive the vaccination being asked to check in with the FDA regarding reactions and over what period of time? And the other one is, after receiving the vaccination, how soon can you go back to your regular duties?
Your medical provider should definitely report any adverse effects to a VAERS system, which is an adverse effect reporting system. But the CDC is also launching something called vSafe and encouraging anyone who gets vaccinated to enroll. And what vSafe does is it'll message you every day for the first, I believe, week after you get the vaccine to ask you if you've had any effects, maleffects. And then it checks on you, I think, at the 3-week mark and the 6-week mark. So there is a system that the CDC is highly encouraging people to enroll in after you get the vaccine to report any possible side effects.
And as the employer of 3,000 people that we're going to vaccinate, they'll be returning to work in about 1 second.
Okay, that was a good one. This is, what are plans to vaccinate community physicians and their office staff?
It's a great question. Dr. Neeley answered the question for our medical staff, which is about 700 physicians. A relatively small percentage, maybe 25 to 30% of those physicians are in our hospital all the time, and they're obviously all in tier 1. But we intend to vaccinate all members of our medical staff who are willing to be vaccinated, both because they'll be in our facility and secondarily because we want their office practice to be a safe practice as well. I think the bigger question is, how do we figure out how to help physicians who are private business owners vaccinate their staff? And we don't yet have an answer for that either.
Is the vaccine recommended for someone who's already tested positive for COVID?
Yes, it is.
How long will the vaccine last, or will we have to get vaccinated every year like the flu vaccine?
That's the $1 million question. We don't know yet. We don't know how long the vaccine will last, so when we will need a booster. And we also don't know if the virus is going to become a friend of ours like the influenza virus that mutates every year, necessitating us to actually offer a revised or new vaccine every year. A lot of big questions like that remain open, and it's only through time and continued study that we're going to learn these things. And if I could put one more plug in for science, we need scientists and clinicians, people who actually study real data and communicate that data to us in order to answer these questions. It's not going to be answered by Facebook.
Yeah, we've actually, Scott and I participated on a call where they said, and this is a medical person said, it only lasts for 2 months. Well, according to, if you read the document that Pfizer put up, that's the period in which they followed people. And they had, X% of the people had been followed for a 60-day period. They don't know beyond that because they didn't follow them yet, but they will, and we'll have answers to some of these questions as time goes on.
Another question, this is for Dr. Park, is what steps in San Joaquin County are being taken to ensure residents in South Stockton and other underserved areas receive the vaccine equitably?
So we continue to plan and do our planning phase. And as I said, we continue to receive word from the state in bits and pieces about who's next and what's next in the tiers. We definitely are looking at equity as we go along. We do know that there are certain communities that might be more hesitant to be vaccinated. So we're going to be engaging with those communities. Right now, we're reaching out to our community business organizations to see if they can help us with that messaging because they know their communities better and their communities do listen to them and take their advice. We're also looking at talking to people who might be push partners, some of our bigger corporations out and around the county that might be in some underserved areas. Can they act as areas where we could do mass vaccination pods to get our community vaccinated? So all of that is in the planning phases right now, but thank you.
So a few more questions, and I think we've answered this one, but I'm continuing to get them. How will people that are in other tiers know when it's time to get their vaccine and where would they get it?
Stay tuned.
Once we know, we'll let you know. The state is looking at this. They have meetings pretty much for hours and hours at a time. As you know, they have an advisory council, and governor's put together a drafting council. They're looking at what the CDC suggests, and then they're meeting and talking. And as they tell us who's going to be next in phase 1B, we'll be telling you. So even right now, we don't know exactly about the phases 2, 3, and 4. They're working very hard on just pinning down phase 1B. And we hope to know more about that by next week.
And I think this one last question, it's actually two that I'm combining, is how do we know if there are any long-term effects from the vaccine? And there's concerns that there isn't enough information about side effects. Isn't it too soon to be confident in the vaccine?
I'd like to answer that one.
Go ahead, Doctor.
First off, vaccine medicine and knowledge has been around for a long time. And despite an assault by a non-knowledge, non-science-based group within our society, vaccination remains one of the safest and most effective ways to keep people healthy and to prevent disease. And what we can say from our previous experience with vaccine, which really now goes back hundreds of years, is that vaccine complications that are medically significant almost always occur within the first couple of months after a person receives vaccination. While there have been a lot of hypothesizing about longer-term effects of vaccine, true scientifically based knowledge regarding long-term effects of vaccine have basically not panned out. And what we can say with a great deal of confidence is that based on what we know right now, the chances of dying or having significant complications as a result of COVID infection far outweigh anything that's been seen in the vaccine trials so far. Maggie, I'd like to just ask you if you have something to add to that.
So yeah, thank you, Dr. Neeley. With the Pfizer vaccine, the biggest complication or side effect would be the local pain at the injection site, which is the case for any shot that you receive. Not so much the redness or the swelling. And then some people do have some systemic symptoms, such as the fatigue, the muscle aches, the joint pains, some fever. Those are all, things that might be expected, but are not happening in everyone. And then we haven't really heard about other systemic side effects that have been a big concern. And Moderna seems to be right along with Pfizer to have some very mild systemic side effects. So the adverse side effect profiles seem to be quite low for both of these vaccines.
One last question. Dr. Neeley, you're a frontline healthcare worker. Have you been vaccinated?
I have.
Very good. I'm not. I have not been. But if they have a thawed dose that they want to give away at the end of one of these days, I'm in line.
I'm a frontline healthcare worker, and I am in a high-risk group as well. So,
not as high as mine.
Only a couple of years.
All right. Well, we are so grateful for all the people who joined us today, and to Dr. Neeley and Dr. Parks, who did just a terrific job answering these are difficult questions, some which don't have answers yet. And I really appreciate the expertise and the time. And I know everybody who joined us today did as well. Thank you all so much, and have a great weekend. We will do another one of these in a month or so. Thank you very much, and goodbye.
Thank you.